This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. All right, welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. I'm a med-peds trained pediatric hospitalist here at UPMC, Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. Now, we've been coming to you since October of 2016 with these PHM from Pittsburgh continuing medical education episodes. What we have been trying to do, we have these special journal club series, which is what you've tuned into. This is something we started now a couple years ago that we are finishing up. And the goal of this was to try to figure out how to cover the research part of our content specifications from the American Board of Pediatrics. This is for everybody, pediatricians, pediatric hospitalists, ED docs, whomever. We all need to be able to critically evaluate the literature. And trying to do this in an audio-only format, as you can imagine, is a difficult challenge that we were excited and had some trepidation in taking on. But to pull this off, we have partnered with our colleagues at Dell Children's Medical Center in Austin, Texas, and Dr. Philana Ling Lin, and a group of experts here from both the University of Texas at Austin and the University of Pittsburgh. You're going to meet various of them throughout this series, and we couldn't have done it without their help. One of those experts is here with us today, back for episode 11, and that's a friend of the podcast, Dr. Matthew Wilkinson. Now, just in case you're tuning into this one for the first time, Dr. Wilkinson received his BA from Harvard University, his MD from the University of Connecticut, and his MPH from the University of Texas. He completed his residency in pediatrics at Children's Hospital of Austin and fellowship at Pediatric Emergency Medicine in Pediatric Emergency Medicine at Phoenix Children's Hospital. He currently works in an emergency department at Dell Children's Medical Center in Austin, Texas. Dr. Wilkinson is an associate professor of pediatrics, the research director for the Pediatric Emergency Medicine Fellowship, and the assistant chair of clinical research at the University of Texas at Austin Dell Medical School. He has published several industry-funded drug and device trials relating to the treatment of acute pediatric asthma. His other research interests include pediatric fever evaluation and procedural sedation. So, Dr. Wilkinson, welcome back. Thank you for joining us.
Thank you, Tony, for having me again. I appreciate it.
Matt, we are going to do our disclosure statements for episode 11. I will go first and kick it out to you. I was on the advisory board at the Sanofi Corporation discussing increasing vaccination rate in immunocompromised children, which should have no bearing on what we're talking about today.
And Tony, I am the co-founder and a board member of a medical device company called EM Device Lab, and we should not be discussing any of those endeavors either.
All right. Now, we are here for episode 11. Episode 11 is measurement of association and effect again, but this time we're looking at correlation and causation. So, Matt, like episode 10, I'm going to start you out with the same kind of question. Why does this matter for us when we're trying to critically evaluate the literature?
So, thank you, Tony. This is actually one of my favorite topics to talk about. And we should start with the old phrase, correlation does not imply causation, which is no more true than it is in medicine. And this is a concept that gets confused, manipulated, misused constantly. And even in, very high quality journals, you'll see this issue come up. And so, you'll see terms often in the title of the manuscript or in the abstract, things like is associated with or is correlated with or relationship. Like those are the appropriate terms. But saying things like A causes B or X causes Y, that's a big leap. And in order to make that leap, there are certain things that have to be true. And so in experimental studies, so randomized controlled trials, if they're well designed, usually you can make causative associations between some sort of exposure and some sort of outcome. But in epidemiologic research and retrospective studies, cohort studies, and observational studies, you have to be very, very careful because finding associations between different exposures and outcomes doesn't always mean that one caused the other. And I will give you a very silly example that I use in my talks. I'm going to ask you, do you think that ashtrays cause lung cancer?
I do not. I do not.
Do you think ashtray ownership might be associated with lung cancer?
Associated with, if I smoke, I probably own more ashtrays than if I don't smoke. And I can tell you, I don't think I own any ashtrays in my house because I don't smoke. So I'm going to say yes.
Yeah. So if we did a cross-sectional study and we interviewed, a subset of Americans and asked them, do they own an ashtray and do they have lung cancer? I would almost guarantee you'll find an association between ashtray ownership and lung cancer. But we both know that's not causative. So nothing about having an ashtray leads to lung cancer. But there's a confounder involved, right? So we'll bring up the word confounding now. So there's something else that's driving the relationship that's also associated with owning an ashtray. And as we know, that's smoking, right? Mm-hmm. And so if we control for smoking as an exposure, and we can do this, there's different ways to do this statistically. I use a lot of regression in the studies that we do. So if you do a regression analysis of, things that cause lung cancer and you put into your model as predictor variables, smoking and ashtray ownership, what would happen is ashtray ownership would disappear. It would disappear as a predictor because all of the association is already accounted for by smoking. And so that is just a really kind of basic example of correlation versus causation and the effect of confounding. And so confounding needs to be accounted for when we look at these or try to ascribe anything that may be causative between a predictor and an outcome.
So then to do that, there's no formula for it. And my assumption is you have to be thoughtful about what your variables are and really think about them in a way with probably other people to be certain you're not picking things that are really confounding.
Yeah, that's exactly right. And so, there are different ways to set up these models, talking about regression. And we're all trained a little bit differently on how to do it. Some folks will just throw everything in there and just see what sticks. But the way I was trained is to be more intentional about it. And so when you think about likely relationships based on prior literature, based on biology, based on what we know, and you sort of start with those things. You start with those predictors and you see if the relationship holds. And if it does, then you start adding other things that you think may either be causing the outcome or may be confounding the relationship between predictors you've already identified and the outcome. And so doing it in kind of an intelligent way will lead to the most meaningful and accurate result.
Now, that is fascinating. So then when you're looking at the literature, if you're looking at a study, your goal when they say there's a correlation or there is an association, as a reader, your job is to look at that and say, is it clinically relevant or is there a confounder there that they didn't think about? Is that right?
That's exactly right, Tony. And if you see something that doesn't make a lot of sense, you need to ask yourself, did they control for potential confounders? They found this association, but they didn't look at potential confounding variables that really could explain away the association they found. And I'll give you an old example, very old. There was a study done, this may have been in the 60s or 70s, that looked at the relationship between aspirin and having an acute MI. And basically, some folks were on aspirin and some weren't. And when they just did the retrospective study, it looked like the people that took aspirin had a greater incidence of MI, which is very strange, right? Like, why would that be? And it turns out that the reason why is because the doctors were putting the high-risk people on aspirin. The really high-risk people were getting put on aspirin, so of course they're going to have MIs at a higher rate. And if you control for their risk factors, aspirin greatly reduced the risk of MI. But if you didn't control for that, this is a bias that we see all the time called bias by indication. And so basically you have to account for somebody's other risk factors, risk of the outcome, adjust for that, and then see if the exposure still has the association.
So looking at like a silly example, if we wanted to say people who listen to podcasts are clearly more intelligent, right? Shout out to the audience. We would be ignoring the fact that perhaps people who listen to podcasts for medical education are putting a lot of time in their medical education, and perhaps that could be the reason why maybe they're doing better on board scores or on whatever.
Yeah, that's a great example. Yeah. So does listening to a podcast increase your board scores? And so if we do a cross-sectional study and ask people what they got on their boards, ask if they listen to podcasts, you would probably see an association. You're right. But the question is, were they always going to do better on their boards no matter what? But they also chose to listen to podcasts because, they're more technologically savvy or whatever the real association is. That's a great example of possible confounding.
Oh, that is fascinating. Now, Matt, this seems so simple. Why is this this took us a few minutes to cover? Why is this such a challenging topic?
I think it's just that when you design a study, you need to be very, you need to think about all the possible things that could affect a relationship at the outset. Because if you don't think about it at the outset, you don't have the information on the back end. And so if I run a study, and I want to look at, does RSV have an infant cause asthma later in life? And so I roll a huge cohort and I start collecting data, and I collect data on the viruses that they're exposed to. And then we go and follow these kids and see if they develop asthma. Well, I didn't think about other things that can confound the relationship between getting RSV and having asthma later in life. And so what if it's that, it's not that they got RSV, it's just that they live in a, poor quality housing or exposed to pollution, and they live in, a cramped environment. So they were more likely to get RSV because of the environment, but also there are other things about the environment that may have caused the asthma. And so if I don't think about those things and plan those things ahead of time, and I don't collect that data, I get to the end of the study and I have these kids with asthma and I can't make adjustments for the things that may have actually confounded the relationship. And so you need to be very intelligent about the design of these studies to make sure that you're getting all the information you need on the back end to make these adjustments.
And can you limit for, let's say, your example of RSV, can you set up the study to where you're accounting for poorer quality housing, cramped living conditions, et cetera?
Yeah, so different ways to do it. I mean, the easiest way in an observational study is just collect the data. And so if you collect the information, if you have the information, you can do adjustments on the backside, but you have to have the information. And so this gets to one other thing that we should discuss, and that's sort of the beauty and brilliance of randomized controlled trials. So why they're so powerful is because not only are you balancing all the confounders between the groups, at least theoretically when you randomize, you're balancing confounders that you can measure. And if you can measure them, you could always do adjustments after the fact if your randomization, was off. But you're also balancing confounders that you don't know about and you can't measure. And that's the beauty of randomized controlled trials, is you're balancing all the confounders between the two groups, ones that you know about and even ones that you may not know about.
And how are you doing that for the ones you don't know about? Because you're selecting these groups yourself, or how are you doing that?
Because at least in theory, when you randomize, they should be relatively balanced on all of the other variables, all of the other exposure variables, all the other predictive variables should balance out, at least in theory. And you'll see, your table 1 in a randomized controlled trial is for this purpose. It's trying to show the reader the randomization worked. And so you'll see gender, race, ethnicity, insurance status. In an asthma trial, they'll have what's their baseline asthma severity, what's their presenting respiratory rate, asthma score. And you can compare the two groups and see that, yeah, they were about the same, or maybe they weren't, and you have to do some adjustment after the fact. But that's for the things you know about. But the beauty of that sort of trial design is that you're balancing things you didn't know about, didn't account for. There might be genetic things that are, predisposing to worse asthma that we don't know about right now. But the randomization balances all potential confounders.
So then the odds, shout out to episode 10, of you having a more balanced group significantly goes up when you do a randomized control trial versus a retrospective trial where you're collecting whatever happened.
That's exactly right. And, sometimes you'll see in randomized controlled trials that they'll still do some adjustments, some regression, especially if it looks like there's an imbalance of some baseline characteristic that's known to confound the relationship between the predictor and the outcome. You'll see some aggression, and I've done that on some of our studies. And, in theory, you shouldn't have to do that. But if you find a baseline characteristic that just because of pure chance, was uneven between the two groups, you can do adjustments. But again, what the randomization does is it's supposed to balance all baseline characteristics or all confounding variables.
That is fascinating. And so then the papers we have been using for the podcast, one of them is from Dr. Courtney et al., bolus versus continuous nasogastric feeds for infants with bronchiolitis, a randomized trial published in Hospital Pediatrics, Volume 12, Issue 1, January 2022. That's one of the reasons we love that study so much, is because it's a randomized controlled trial and really accounting for all the variables we thought of and some we didn't even think about.
That's right. Yeah. And, you can pull up that table one and you can go and look at the two different groups and see that they're, pretty similar on all of the baseline characteristics. And they included, many things that could confound the relationship between the predictor and the outcome, especially when you're talking about, length of stay. There are many characteristics about the child or the presentation that could affect that. And they show you here, in, very explicit terms, exactly what those characters, the proportion of kids in each group that had each one of those characteristics, just to show you that the groups were pretty even.
Well, now this has been a great conversation, Matt. Is there anything about this you wanted to talk about that we didn't bring up?
Let me just really quick talk about this concept of the Bradford-Hill criteria. And this is something, again, we talk about in the lectures. So, it's often not possible to do a randomized controlled trial. That's the gold standard. We wish we could do that for everything. And I'm going to go back to the smoking example. This is one I like. I think it resonates with people. So, Tony, do you believe that smoking causes lung cancer?
I think it increases your risk significantly.
Do you think that, so is there a causal relationship? Like, is it somehow causing it, or is it just associated with lung cancer?
I think it's causing it.
Yeah, I think most of us believe it's causing it.
Yes.
What if I told you that I found a gene, and that gene makes people highly addicted to nicotine and also causes lung cancer? So if you have this gene, you're going to get lung cancer, but you're way more likely to be addicted to cigarettes. Does that sound reasonable?
Yeah.
That's an argument that was put forward back in the day by some of the litigators on the side of big tobacco.
Oh, wow.
And how could you disprove that?
Right.
Are you going to design a randomized controlled trial where you tell half the people they have to smoke their entire life and the other half that they don't? I mean, it's not going to happen, right? It's unethical. Right. It's improbable. So that will never happen. So how do we then, try to prove that, a relationship we're seeing is probably causal? And so Sir Austin Bradford Hill in the 1960s came up with basically a list of things that we should pay attention to try and decide if a relationship is causal. And I'll just go through a couple of them because I think this is how we should think about, observational research, retrospective research, anything that can't be done experimentally. It still has meaning. And, these are some of the criteria that we use. So strength of association. So if there's a strong association, a strong effect size, it's probably more likely causal. And we know that the effect size between smoking and lung cancer is large. It should be consistent. So it should be reproduced through studies. So if there's been 10 publications on this concept and they're all consistent, that builds evidence as well. There needs to be a temporal association. So this is why cross-sectional studies, it's a bit of a weakness. So knowing that two things are associated doesn't mean that one preceded the other. So you want to know temporality, and which is why we like cohort studies. Plausibility. There should be some plausible mechanism. It's, cigarettes have hundreds or thousands of chemicals in there that are possible carcinogens. So there's biological plausibility. And then a dose-response relationship. So we can do a study where we look at not only do you smoke or not, but how much do you smoke? And do the heavy smokers have a higher rate of disease than light smokers? And so those are some of the criteria that we use to basically say, look, this association is probably causal. And I think the smoking and the cancer example kind of bears all of those out.
And so we can go through this checklist whenever we have a paper that is showing some sort of relationship, whether causal or even just associated, to see if it's likely to be causal.
Yeah, that's right. And then go to the literature and see, is this something that we've seen before? Does this make sense? Is there consistency? And then, at the end of the day, you're making your own decisions as a consumer of the medical literature. You're reading these things with an intelligent eye, knowing these concepts and saying, look, I think this is probably real and this is something I should tell my patients about.
That is okay. I'm going to definitely, could I ask you to send me the paper that Sir Austin, is it Sir Austin?
Yeah, they're called the Bradford Hill criteria. So Austin Bradford Hill.
We'll put that in our references for this. I haven't heard that before. That's fantastic. For this episode, so people can find it if they need it. The Bradford Hill criteria. That is fantastic, and he was knighted for this. Even better. Matt, anything else?
I think that covers it, Tony. Thank you.
I can't thank you enough. This was really great. This was a topic I wasn't sure how it was going to go because it's such a tough topic for people, and I liked it a lot. I learned a lot from it. So I appreciate it.
I really appreciate that, Tony. Thank you.
All right, and we'll see you next time.
Thank you for joining us for this Journal Club series at PHM from Pittsburgh. We want to especially thank our expert guests for their time.
Special thanks to the University of Pittsburgh for sponsoring the CME for this podcast, and UPMC Children's Hospital of Pittsburgh for supporting this podcast as well. We want to thank our friends at Dell Children's Medical Center and the University of Texas at Austin for their partnership on this endeavor.
Please email my dad at tony.tarchichi@chp.edu with any questions or comments. And as always,
thank you for listening.